Bismillahir Rahmanir Rahim. Assalamu alaikum. My dear students, today I am going to talk about allergic rhinitis. Now, allergic rhinitis, by definition, is inflammation of the nasal mucosa as a result of allergy. Now, one would ask what one means by allergy. Now, allergy should be defined or can be defined as altered reactivity of the body. Allergy is a state of altered reactivity of the body, and if it occurs in the nasal cavity, causing inflammation of the nasal mucosa, we call it allergic rhinitis. Now, allergy of the body in general can be due to very many factors. Nasal allergy most often is due to inhalant allergens, but sometimes it can be due to ingestants as well, like, for example, eggs, milk. Certain people are allergic to eggs. Certain others are allergic to milk. An ingestion of milk and eggs sometimes may lead to the manifestations of allergy in the nasal cavity. But most often, as I said before, it is usually due to inhalant allergens that one suffers from allergic type of rhinitis. Now, rhinitis due to allergy is not only due to allergy itself, but it's more common in people who suffer from a susceptibility of allergy, whose family has got a family history of allergy, or it's atopic tendency in the particular person. He may be suffering from other types of allergy of the body. For example, dermatitis. For example, allergy due to certain ingestants. Or, for example, allergic type of asthma. These are examples of people who have got a tendency to develop allergy. Now, allergic rhinitis is usually due to inhalant allergens. And inhalant allergens in the form of perfumes, in the form of certain sprays, certain chemicals. But most common type of inhalant allergy in human beings is due to dust mite and house dust mite. These, as well as certain other factors like certain animals whose furs or hair may lead to allergic rhinitis. In other cases, one can have allergy due to feathers. Say, for example, some people have pets in their houses and they can suffer from allergy in that sense due to the feathers. So let's just talk about causes of allergy and how we manage allergic type of rhinitis. Bismillahir Rahmanir Rahim. Allergic rhinitis. Well, by definition, allergy is a state of altered reactivity of the body. Different people have described allergy in their own ways, but I think this is the best of definitions for allergy. Whereas rhinitis is inflammation of mucous membrane of the nose. So when allergy is combined with rhinitis, we call it allergic rhinitis. Allergic rhinitis is a very common ailment. 10 to 20% annual prevalence in these cases, whereas there's male predominance and more common in young adults. About 10% of all visits to physicians is because of allergic rhinitis. Talking about types of allergic rhinitis, there is seasonal type, there is perennial type, or episodic and occupational types. In the seasonal type, it's usually due to pollens and outdoor molds, or the spores of fungi, or tree pollens, or grass pollens. Perennial type of allergic rhinitis is usually due to human dander or house dust and house dust mite, which is called dermatophagoides stercoralis, and animal fur, feathers, molds, etc. Episodic type of allergic rhinitis can be due to anything the person is allergic to, but it occurs in episodes, and when the thing is taken away, then the episode is over. Whereas occupational type of allergic rhinitis occurs in those type of people who are attached to certain occupations like mercury industry or platinum industry or acid industries like chromic acid and so on. Now, ARIA classification of allergic rhinitis describes allergic rhinitis into two types: intermittent, persistent, mild or moderate to severe. Now, intermittent symptoms with mild type of allergic rhinitis, people say that they can sleep normally, they've got normal daily activities, normal work and school, and there's no troublesome symptoms. Whereas persistent symptoms with moderate to severe causes abnormal sleep, impairment of daily activities, abnormal school or work, troublesome symptoms. As I told you before, causes of allergic rhinitis we have just summarized in this picture. There are certain types of allergens one can inhale, and other types one can ingest or swallow. And allergic rhinitis is usually due to inhaled allergens, whereas in certain other cases one can have allergic rhinitis because of ingested allergens. Now, for example, pollens, grasses and weeds, they lead to seasonal type of allergic rhinitis, which occurs only during the pollen season. Like, for example, hay fever occurs in March and April, when the flowers spread pollens in the atmosphere. Whereas other type of inhalant allergens like cause perennial allergic rhinitis, like house dust, dust mite, animal dander, and feathers from animals or birds. Feathers usually from birds. Now, this is due to inhaled allergens and causes perennial type of allergic rhinitis, which runs throughout the year. Where certain ingested allergens like wheat, eggs, milk, or nuts, they give rise to certain type of perennial allergic rhinitis as well, but in certain individuals only. When we talk about occupational allergens, we've got latex industry, health professionals and patients from latest industry can have occupational allergies. Drugs like pharmaceutical workers may also have allergic type of rhinitis, and flour industry like bakers and grain workers may also have allergic type of rhinitis. Animal gender, people who work in the labs with animals may have animal gender allergy, whereas wood dust can occur in carpenters and sawmill workers. Washing powders, soap powder and manufacturers can suffer from allergic type of rhinitis, and platinum salt refiners can also have allergic type of rhinitis. These are all examples of occupational type of allergens, where certain foods can also act as allergens for certain individuals, like preservatives used in food industry, sulfites, benzoates, tartrazine. Histamine-rich food like cheese, fish, birch pollen, which occurs in apple, tomato, in apple and tomato, potato, almond, walnuts, cashew nut, cherry, and carrots. Grass pollens, like for example in beans, pea, wheat, and rye. Mugwort pollen, like banana, melon, cow's milk, goat and sheep milk, hen's eggs, and meat. Peanut, which occurs in peas and beans. As far as etiology of allergic rhinitis is concerned, one can talk about genetic predisposition, which we call atopy. Atopy is genetic predisposition to having allergy, like for instance infantile eczema or allergic asthma, nasal and conjunctival allergy. And susceptibility of person also causes, or one can have etiological cause due to susceptibility of a person to a certain type of allergy. Inhaled allergens cause allergic rhinitis usually. Pathogenesis. Now, allergic type of rhinitis is immunoglobulin E mediated hypersensitivity type 1 reaction. Now, in this type of reaction, allergens, they have a reaction against antibodies, which is immunoglobulin E. So allergen and immunoglobulin E antibodies, they make antigen-antibody complexes which then attach with mast cells and basophils. And these antigen or allergen antibody complexes lead to degranulation of the mast cells and basophils and cause release of mediators of allergy. And those mediators are histamine, leukotrienes, prostaglandins, tryptase, heparin, cheekin. As far as allergens are concerned, we talk about pollens, trees and grass pollens, house dust mite, human dander, animal fur and feathers, fungus and molds. Symptoms of allergic rhinitis. There can be specific symptoms and there can be non-specific symptoms. Now, first of all, the specific symptoms, usually sneezing bouts, 10 to 20 sneezes at a time, and then watery rhinorrhea, a watery discharge from the nasal cavity, and there is itching in the nose, eyes and palate. There is disturbed sense of smell or diminished sense of smell called hyposmia. In certain other cases of long-term allergy, one complains of loss of sense of smell, which we call anosmia. Now, nasal obstruction can also occur as a symptom, and post-nasal discharge or post-nasal drip. Then non-specific symptoms can be earache due to ear pressure, itching and irritation in the eyes, watering of eyes. Symptoms of superimposed infection can also occur later on. When we take a history from a patient who is suffering from allergic rhinitis, it's very important to concentrate upon certain facts, such as one has to ask about the nature of this nature exposure, such as flower season, patient may complain of allergic symptoms in the flower season only, which we call hay fever. Similarly, we have to ask about the duration of symptoms. Say, for example, in the pollen season, allergy is usually limited to the season. Say, for example, 2-3 months of the season, the patient has got symptoms, and the rest of the year is all right. So duration is also important. Then frequency, how often the patient gets the symptoms. And the seasonal changes needs to be asked about, such as if there's a flower season and the patient gets the symptoms in the flower season, then we usually concentrate upon the types of flowers which the patient may get allergy to. Now, environmental exposure is also important. Say, for example, a patient may get the symptoms in damp atmosphere and may be all right in the dry season. Occupation is also important in allergic type of rhinitis, as we have already talked about certain occupational types of allergens. Whereas family history is also important in allergic rhinitis, because this allergic rhinitis is known to run in families. Whereas comorbidities like asthma is also important to know about, since about 25% of allergic rhinitis patients may also suffer from asthma. As far as the signs are concerned, what do we see in the nasal cavity? We can see edematous, pale nasal mucosa. We can see excessive mucus or watery secretions in the nose. And allergic salute is a line, a dark brown line, which occurs in the mid part of the nasal bridge due to the patient wiping the nose from down to upwards with the palm of the hand. There may be boggy inferior turbinates. There can be signs of allergy in the ears, pharynx and larynx. This is a picture of the allergic salute. Here one can see the crease on the nasal bridge because of the child wiping the nose from downwards to upwards. Now, other signs of allergic rhinitis can be manifest in other areas like the ears, like the pharynx, like the eyes, like the larynx. Now, one by one, Otologic signs, one may have otitis media with retracted eardrums or eustachian tube blockage, whereas pharyngeal signs can be pharyngitis or adenoid hyperplasia, and prolonged mouth breathing in children may be apparent. Ocular signs like edema of eyelids or allergic shyness, which is a brownish discoloration under the eyes. Cobblestone appearance of conjunctiva due to congestion. Now, laryngeal signs can be hoarseness of voice and edema of vocal cords. Investigations for a patient with allergic type of rhinitis. One can do a blood CP, complete picture, which usually shows eosinophilia. Nasal smear, seen under the microscope, one may find a lot of eosinophils in the nasal secretions. Whereas skin allergy tests should be done to identify the allergen. A nasal provocation test, which tells us about a particular type of allergen that the patient may be allergic to. Patch test. In this test, the allergen is applied to the skin in the form of a patch, and the reaction is read about 15 to 20 minutes later. There are certain antibody tests like radioallergosorbent test, RAST, which shows the specific type of immunoglobulin in the patient's blood to a particular allergen. Whereas PRIST, P-R-I-S-T, is plasma radioimmunosorbent test. This also shows particular or specific type of antibody in the blood of the allergic patient. Now, X-ray of sinuses like Waters view, occipital frontal view, and lateral views, they all show sometimes nasal mucosal changes such as edema of the mucosa or bogginess or sometimes polypidal changes in the nasal and sinus mucosa. Now, as far as skin allergy tests concerned, we'll talk about them in a minute. Skin prick test, SPT. Allergen is introduced into the skin. It causes degranulation of immunoglobulin E sensitized mast cells with mediator release and formation of a wheal and flare. It's simple, cheap and safe, and low risk of systemic reactions. Always undertaken where emergency equipment and resuscitation capable staff is available. Now, skin prick test should not be performed in patients on antihistamines or with severe eczema, previous anaphylaxis, or dermographism. Positive results, reaction is usually more than 2 mm in under 5 years of age patients and more than 3 mm in adults. Positive results should be at least 2 mm greater than the negative control, where positive skin prick test occurs in 20 to 30% of adults, but only 10 to 15% develop symptoms. Now, there's another test called intradermal testing. In this test, about 0.5 ml or to 1 ml of a sterile syringe with 26 gauge intradermal needle is used to inject 0.02 to 0.03 milliliter of intradermal allergen. The needle is inserted with the bevel facing upwards and the syringe parallel to the skin The skin is penetrated superficially and a small amount of allergen solution is injected to create a bleb raised area approximately 5 mm in diameter. A separate sterile syringe and needle are used for each injection. This again is comparable to the skin prick test. Now, immunoassay versus skin test for diagnosis of allergy. Immunoassay like the RAS test, radioallergosorbent test, or the PRICE, plasma radioimmunosorbent test, are the immunoassays. Whereas skin test, like we just talked about, intradermal testing or skin prick test versus the RAS and PRICE. Now, immunoassay is not influenced by medication and it's not influenced by skin disease, does not require expertise and quality control possible, but the only drawback of immunoassay is it's expensive. Whereas skin test has a higher sensitivity, it gives immediate results, it requires expertise to read the results, but it's cheaper. Now, nasal allergen challenge, also called nasal provocation. In this test, allergen is introduced into the nose and any reaction is measured and compared to placebo. This is the gold standard of allergy diagnosis, but is rarely necessary. The allergen should be applied in gradually increasing concentrations with careful monitoring. Nasal challenge testing is time-consuming, difficult, and requires extensive laboratory facilities. As far as differential diagnosis of allergic rhinitis is concerned, one has got a whole battery of things. It's a whole list, like for instance, non-allergic type of rhinitis, infections, vasomotor rhinitis, atrophic rhinitis, drug-induced, hormonally induced, exercise, reflex, structural mechanical factors, septal deviation, turbinate hypertrophy and adenoids, hypertrophy, foreign bodies, tumors, inflammatory and immunologic like vagus, sarcoidosis, midline granuloma, systemic lupus erythematosus, Sjogren's syndrome, and CSF rhinorrhea. Talking about treatment of allergic rhinitis, we've got 4 strategies of treatment. Avoidance of allergens is the first and foremost thing, if that is possible. Treatment with the drugs such as the antihistamines, which are H1 receptor blockers, nasal decongestants, which are sympathomimetic drugs, corticosteroids, and mast cell stabilizers. And immunotherapy is another type of treatment one can consider. And the fourth and the last is surgery for certain conditions. Now, allergen avoidance and prevention. How can we avoid allergens? For example, dust mites. One cannot get rid of dust altogether, but one can at least diminish the dust or reduce its amount. It can be avoided by using pillow and mattress covers, doing frequent vacuum cleaning, and proper ventilation. Animals which cause allergic rhinitis, if one has got pets at the house, then one can remove the pets and get rid of the allergic rhinitis. Removing furred animals living in separate rooms and frequent cleaning can diminish allergic rhinitis due to animals as well. Pollens, shutting windows of cars and houses, using masks, avoiding grassy fields can reduce the amount of pollen and lead to diminution in the allergic rhinitis. Talking about immunotherapy, repeated administration of an allergen extract in order to induce immunological tolerance with a reduction in clinical symptoms and requirements for medication during subsequent natural allergen exposure. Now, it's indicated in those patients of allergic rhinitis who fail to respond adequately to usual treatment with antihistamines and topical corticosteroids. In view of the side effects associated with subcutaneous immunotherapy, alternative strategies have been considered. The sublingual route involves application of allergen as drops or tablets under the tongue, where they are retained for several minutes. Now, what are the indications for immunotherapy in allergic rhinitis? There are certain inclusion criteria, and there are certain contraindications to it. Talking about inclusion criteria, we've got immunoglobulin E-mediated disease, which is proven by the skin prick test or RAS. There is inability to avoid allergen, inadequacy of drug treatment, patients who understand risks and limitations of treatment. But contraindications to immunotherapy: if there is coexistent asthma, or patients taking beta blockers, and others like medical and immunological diseases, and small children below the age of 5 years, and pregnancy are the contraindications. As far as oral antihistamines are concerned, there are certain first-generation agents and there are certain newer agents. Now, the difference between the two: the first-generation agents usually are sedative as well, whereas newer agents are said to be non-sedating. So, the chlorpheniramine, brompheniramine, diphenhydramine, promethazine, tripyrrolidine, hydroxyzine, azatidine, these are first-generation agents, whereas newer agents: acrivastine, azilastine, cetirizine, desloratadine, fexofenadine, levocetirizine, and mesolastine are certain newer agents causing less sedation. As far as steroids are concerned, we've got two types of treatment available: oral steroids as well as topical steroids. Now, oral steroids best for severe acute allergy, and it's reserved for refractory cases to topical steroid treatment. Topical steroids, on the other hand, are first-line treatment. They act in late phase of allergic rhinitis. They're available as propellant inhalers and aqueous sprays, and later are well tolerated. Corticosteroid sprays, as far as the types and names are concerned, can be very many, like dexamethasone, beclomethasone, flinisolide, triamcinolone, budesonide, fluticasone, mometasone. Complications of these steroids can be nasal irritation, dryness inside the nasal cavity, crusting, nasal bleeding, perforation of the nasal septum, local infection, systemic side effects with very high doses, and failure due to non-compliance. Now, as opposed to corticosteroids, we have also got mast cell stabilizers used as preventives, or they are safe to use. They can be used both in acute and late symptoms. Preparations available are sodium chromoglycate as a topical spray and ketotifen in the oral form. Decongestants like symptomatic improvement in nasal blockage due to decongestants. Topical preparations should not be used for more than 2 weeks at a time. Rhinitis medicamentosa is the usual complication of a prolonged use of sympathomimetic decongestants. Complications of allergic rhinitis can be nasal polyps development, sinusitis, otitis media, palatal abnormality, sleep apnea, dental problems, and bronchial asthma. Thank you very much.